response to the COVID-19 pandemic. This is a WHO EPI-WIN webinar supported by the Collective Service. The Collective Service is a collaboration between WHO, UNICEF, IFRC, and the Global Outbreak and Alert Response Network. Before I get started, I just want to touch on something. We've been running these series of webinars that really are focusing in on practical approaches for risk communication and community engagement throughout this response. And we'd like to continue these series beyond even the COVID-19 response as being very practical approaches for national level responders. We're looking for a name for the series just to help distinguish it from the many, many other EPI-WIN webinars. So if you have any creative ideas, we invite you to either share them in the chat today or even email EPI-WIN for a series name. We'd really be interested, and then perhaps during our next program, we can take a vote on which series name might win. So for today's program, it's about community involvement in contact tracing. Contact tracing is a strategy that's been used for decades to stop the spread of infectious diseases. Over time, we have learned that implementing contact tracing successfully requires close and consistent engagement with local communities. This includes having community members as part of contact tracing teams and community involvement in the planning, selection and monitoring of methodologies, sensitization strategies, and simply getting the word out about contact tracing. We're going to hear from a number of different presenters about case studies that articulate how successful implementation of community engagement principles increases the impact and effectiveness of contact tracing. So with that, I'll go ahead and introduce our first presenter. This is going to be my colleague, Tamar Zalk, who also is another risk communication and community engagement technical officer with the World Health Organization. She'll talk about community-centered approaches to contact tracing for COVID-19. Tamar?
Thanks, Mindy. Hi, everyone. Thank you for joining us today, and I'm really excited to present this collaborative piece of work focused on placing communities at the heart of contact tracing. The development of this tool was led by the WHO, but in really close collaboration with the Risk Communication and Community Engagement Collective Service, and more specifically, a subgroup that focuses on community engagement in contact tracing. Mindy has already briefly mentioned the Collective Service and who they are, so I won't really go into detail about that, but instead jump straight into the package. Next slide, please. The contents of the package were selected based on demand from regional and country level partners who expressed the need for operationalized support to build more community-centered contact tracing strategies and approaches and tools. Though contact tracing is a foundational pillar in the COVID-19 response strategy, it is often overlooked and under-resourced. And we really see community-centered contact tracing as a potential solution to these challenges, with resources allocated directly from within communities. Evidence from previous contact tracing efforts, including Ebola, HIV, and tuberculosis, amongst others, shows us that community trust is critical for contact tracing to be successful. And despite this clear recognition of the central role of communities in ending the pandemic, they often remain marginalized from planning and preparedness processes within contact tracing. And so this package was really developed to advocate for the importance of the practice and provide tools that can be easily adapted for a wide variety of contexts. The materials that we're going to go through today, they can stand on their own, or they can be used to complement other tools that support the process, including strategies, implementation plans, and trainings. Next slide, please. So this package was developed to support local and national level planners and implementers, including governments, NGOs, and other stakeholders involved at all stages of the contact tracing process. We felt that by integrating tools in this package, we can build trust and ultimately reduce the transmission of COVID-19, saving lives. Next slide, please. The key principles that you see here make up a list of community engagement fundamentals to ensure that contact tracing strategies work through community-centered approaches. These principles are likely very familiar to you. You may have already seen them before. They've been compiled from key RCCE documents and vetted through collective service partners. And of course, while principles are definitely nice to have, they ring hollow without more specific guidance on how to implement and operationalize them. It's one thing to say, build trust, but it's another thing to say, to build trust, try this. And that's what we've tried to accomplish with this package. As you can see, these principles ring true for more than just contact tracing. They can be used for preparedness and implementation around vaccines and other COVID-19 response activities. Next slide, please. So what you see here is an adapted social ecological model, because evidence demonstrates that social and community factors, including policies and norms, influence the success of outbreak control measures. And we've applied this model to help us identify the barriers and opportunities at all levels which support a contact to fully participate in contact tracing, as well as quarantine upon exposure. The model also illustrates the vital interdependencies among policymakers, the community, the contact tracer, and the individual contact. We believe that by enabling a contact tracer to understand each level of the response context, they're better prepared to identify misgivings and resistance to contact tracing. And it also helps them to offer alternative solutions to improve uptake of the contact tracing activities. Next slide, please. Next slide, please.
Sorry, Tamar, it's there. I see it on my screen. So there might be a delay. I'm sorry when I.
Okay, no problem. Sorry about that. So the working group has put flesh on the principles by sharing specific guidance for contact tracing teams in anticipation of and throughout the process. These examples show how the team can operate with a community engagement focus. And I won't run through all of these right now. They're quite extensive and they make up a large part of the package, but they can be found once it's published. And they can also be found in the extended presentation shared with everyone in attendance today. I want to say, I can't emphasize enough the importance of involving communities at all stages of the process, from the planning to implementation, all the way through to monitoring and evaluation. We talk a lot amongst our colleagues, our partners, stakeholders about the importance of engaging communities, but data tells us that we still have a long way to go in including them meaningfully across the response efforts. Next slide, please. One of the areas that noticeably lacked guidance and support was the development of indicators to measure the impact of community engagement. In order to help fill this gap, we developed key indicators that correspond with each of the 11 principles that were shown on the slide before. These are only suggested indicators. There are obviously numerous other ways to measure impact, but the package emphasizes the importance of monitoring and evaluation and ensuring that data collected is used to iteratively improve upon the contact tracing process and activities. Next slide, please. So what you see here is just a snapshot of a wider indicator bank that has been developed to support the monitoring and evaluation process. The indicator bank provides really detailed information for monitoring and evaluation specialists on who should collect the indicators, how they should be calculated and collected, as well as their purpose and why they are important. The indicators link directly to the social ecological model I just showed you, and they are used to show how community engagement strengthens contact tracing and has a positive impact on individual outcomes and societal and interpersonal outputs. Next slide, please. So the last tool of the package is actually a vetted resource guide. And the resources in the guide range from just overall guidance around RCCE, of course, related to contact tracing, as well as best practice and relevant trainings and communications materials that can be used by implementers. And we've really tried our best to focus this on COVID-19 contact tracing, but of course, there were some really incredible tools that were already developed for Ebola and other contact tracing approaches that we have included in this. Last slide, please. So just some things to consider as you listen to the incredible case studies that are going to follow me today. We know that community partnership is really imperative for successful and sustainable contact tracing efforts. And I hope I've really pounded that in today. But also that we've seen over time that working as integrated teams of tracers, health workers, and mobilizers really improves results given workforce scarcity. And the last is that training and monitoring evaluation are paramount to efficient and impactful contact tracing efforts. So with that, I'm going to leave you with my colleagues who are going to share their experience designing and implementing community-centered contact tracing processes. And thanks so much.
Great, thanks, Tamar. So next we're going to move over to hearing a country level example. We're going to hear from Gabriela Poller-Harteg, who's the head of the international relations at the Austrian Red Cross, who's going to talk about utilizing community engagement principles to regain trust in digital contact tracing tools. Gabriela?
Thank you very much, Melinda. Hello, everyone. I'm really delighted to take you on a short journey to Austria today and to introduce you to our Stop Corona smartphone app and to how we utilized community engagement principles to gain trust in this application. Next slide, please. So the 25th of March 2020 was a historic date for us at the Austrian Red Cross. After 3 weeks of intense work, our Stop Corona smartphone app was released and available in app stores. The idea was based on the insight that digital contact tracing might be an efficient community engaging approach to halt the spread of the virus. The app was the first digital contact tracing app to be launched in Europe. It was developed, as I said, by the Austrian Red Cross in cooperation with software developers and in collaboration with the Ministry of Health for the promotion of the app. We were all, of course, very proud of this app and of our achievement, but very soon we had to acknowledge certain limitations and to make an interesting experience. Because the very high values of trust the Red Cross brand usually enjoys with the population did not automatically transfer into the digital sphere. Next slide, please. Acceptance was devastating. Out of 67% of the general population who knew about the app, only 13% had installed it and only 7% used it on a regular basis. This was back in June 2020. Today, in April 2021, we have 1.4 million downloads, but it's still not very much because it means around 650,000 active users or 7% of the total population. So what had happened? Being a champion in a field where Red Cross society usually does not belong to the early birds and the experts brought about challenges. With the app available in stores, we immediately got involved in an unusual debate for a Red Cross society. We became part of a public discussion about privacy rights, state surveillance, and digital control. On top of that, political interference further damaged the image of the app and triggered skepticism in the population. Debate about a possible obligation of the app really damaged the image and download figures remained rather low. Next slide, please. So before I elaborate a bit more on how a community-centered approach has helped us to regain trust, I would like to hear from you. What do you think? What is your estimation about the reasons why people decide not to use digital contact tracing tools? Vicky, could you start the poll, please?
Yes.
Thank you.
Can you see it? I think
yes.
It's launched.
Yes. It's
so
there.
Can we please ask you to start voting now? Thank you. Okay, it started. Thank you. So you have 5 options here: fear of state surveillance, data protection issues, doubts about effectiveness, technical challenges, and no smartphone user. So maybe we can give you a few more seconds to finalize your vote. Thank you for your participation.
Thank you very much. That's really interesting to see because it resonates very much with a survey we did here in Austria with potential users of the app. If you could see the next slide, please. It's nearly the same. 68% of our poll or survey users said that they don't want to be monitored and they feared mobility data, for example, was being tracked. The second biggest concern was by 58% of the respondents was that they believed personal information and health data was being shared. And 55% were concerned about the effectiveness of the app, which was in fact also related to the low uptaking and the low usage of the app. So to sum it up, we were facing a credibility and trust problem. And as Tamar has elaborated, building trust is a very crucial principle for community engagement and contact tracing. Next slide, please. So with that insight, we started a 3 key principle strategy to regain trust in this application. The first was analyzing feedback, listening to the community, and communicate about what we learned. So by listening to the concerns from the community, we heard that willingness to use the app is highest when it is recommended by family, friends, medical personnel, or trusted institutions. So we strengthened the Red Cross being a trusted institution as the issuer of the app in our communication. 80% said that anonymity and voluntary use are by far the most important aspects that could motivate them to install the app. So we focused again in communication on the voluntary use and the strict privacy by design approach we were following with the app. The second pillar was communicating with transparency and radical openness. So we opened and revealed the source code of the app, made it available for data protection experts for an analysis. And their conclusion was that the decentralized app is a role model for Europe, and they had no concerns about data security and data protection. And the third pillar was creating partnerships by including the tech community, as I already mentioned, but also by including the humanitarian community, the civil society organizations. We created a platform and transferred the whole responsibility for the further development of the app to this platform that consisted of civil society organizations, partners from church organizations, health institutions, and they, in a very transparent manner, discuss and decide about any further developments and releases of this app. So I think these three pillars really strengthened also our accountability, and we were able to regain a certain level of trust into the application. Next slide, please.
I'm sorry, I think it's frozen. So can you please continue, and I will.
Yeah, sure.
I'm sorry, Gabriela, I would do that.
No worries, it's fine. So if I go back and see what would have been good to know from the beginning on and what are our lessons learned, I would say that communication about the added value for users is a crucial thing. because users usually appreciate to be part of the solution and see their actions as an active role and socially relevant in the fight against the pandemic. And the app also contributes to a sense of security for the people using it. And it's definitely worth to consider the 11 principles of community engagement as elaborated by Tamar, because our experience has really clearly shown that effective, inclusive, sustainable, and accountable contact tracing efforts are the only way to gain acceptance by the population. And I thank you very much for your attention. Thank you.
Thanks so much, Gabriella. It's very interesting. And thank you, Tamar. So we'll go to a couple of questions from the participants. Again, I'll invite, I didn't mention this earlier, but if you have any questions for any of the panelists, please go ahead and write them into the Q&A function in Zoom. Also, if you require French translation, we are interpreting this live in French. Please click on the globe button at the bottom of your Zoom. I believe that's where it is on your Zoom screen, and you can get some live French translation. So we'll go to the first question. I think this one will probably be for Tamar. An individual, James Pender, is interested in knowing how using local community members avoids encouraging stigma or bad feelings towards those who are potentially the index cases. There may be more known about this where there's been use in other diseases such as leprosy, Ebola, but they saw this, this individual saw this also with COVID. So just wondering what we think about index cases and potentially wanting to remain anonymous. Tamar, do you think you have an answer for that?
Yeah, sure. Well, I'm guessing that what you mean by local community members, the utilization of local communities is in the contact tracing process. So I'll answer it in that way. And just to say that, one of the reasons I've really emphasized the importance of monitoring and evaluation and these indicators is because there is not a lot of data about this, and not a lot of data measuring the impact of how we run community engagement, particularly not for COVID-19. So, I hope that a year from now, we'll be able to look at this and be able to say a lot more about it. But I think, it's not just about index cases themselves, but just generally overall trust with potential contacts. And, we believe that by engaging people from the communities who are trusted to promote and discuss approaches of contact tracing in the community and the regulations, the rules, and why they're important, why people should participate, that you're able to build and sustain trust for a lot longer. As you heard from Gabriella, it's not just about building trust, you have to sustain it as well. And so by utilizing familiar faces, by utilizing people who understand the community context and perhaps what the index case is going through themselves, allows them to build a relationship that's trusted, and hopefully allows them also to understand that the work that's being done around contact tracing is being done in a way to avoid stigma, and to really ensure that people are not being judged and not targeted because they have COVID-19 and because they have inadvertently spread it. I hope that.
Great, thanks, Tamar. The next, I'll lump a few questions together. This is for Gabriella. First of all, could you describe the objective of the app that you just presented, because it wasn't exactly clear the overall objective of the app, or potentially when this individual asked the question. And did you anticipate some of the barriers that you faced before you launched the app? And then how have you moved forward to gain trust and engagement of communities that have a known low vaccine uptake?
Thanks very much. I'm sorry that it was not entirely clear. The objective was to, in the first place, to really support public contact tracing, which has been done by people answering phone calls from people who feared that they have contracted the virus. And during the first COVID wave here in Austria, it was very soon very clear that this won't be enough, so that the numbers of calls and people will be too much to be handled by individuals. So this was the the initial thought we had. And then, of course, we thought about how can we engage the community, the population here in Austria by fighting this virus. And I think one of the overall objectives is, of course, to save lives. And by saying this, I can maybe present some numbers. As I said, we have around 1.4 million downloads. So far, about 13,000 infections have been reported via the app. This means that surely about 13,000 infections have been avoided, because we think that one person getting an infection might contract or infect another person. So it's about 13,000 avoided cases and around 1,500 avoided deaths. So I think that's quite a good thing. The barriers in the community were, as I said, about trust, but also we experienced with elderly people that they were really feeling insecure in the use of the app and needed very much support. So we also established a telephone helpline and an email account where people can ask and really be helped on an individual basis.
Okay, great. Thanks, Gabriella. A question, and I'll probably go back to Tamar for this one. Is there a specific model of trust and trust building being used? And if so, could you describe that in the work that you've done?
I was just typing that out as you called on me.
So you can read your answer.
I was in the middle, so I might be ending on an I, which won't be very useful to everyone. But, I mean, there's a multitude of ways of building trust, and today we're really emphasizing a community-led approach to building and sustaining trust. And you know, in the package, which I didn't really go into too much detail because it'll be shared with everyone, there are key SOPs for each level of the contact tracing process. So before entering a community, once you've entered a community, and throughout the contact tracing process. But you know, some of the key things that we've seen are really, what are the entry points in a community, ensuring that you enter a community appropriately and through the right venues. Are you working with the right faith leaders, community mobilizers, you know, other influential and trusted people within the community who can help you understand the best way to integrate into that community around contact tracing. The other is looking at in developing, utilizing these people and others from the community to develop the approaches and methodologies, which means that from the very beginning, people are familiar with contact tracing, understand why it's important, and understand, perhaps most importantly, what their role is in contact tracing. And then really listening, continuing to always listen, and then react positively to what you're hearing. So you don't just want to gather feedback from the community, you want to also show that you're listening to that feedback and either actualizing it through your implementation process or responding when you're unable to do so. So explaining to people, we're really sorry, we can't do this because of, and really being transparent with your communication.
Great. Thanks, Tamar. So we're going to conclude the question and answer session right now. I invite you to continue to put your questions in the Q&A function. Some of these are specifically for Gabriella about your app. So if you don't mind going in and answering those live, that would be very helpful. And some of these, maybe we can turn the questions over to our next set of presenters. So next, we're going to move on to Gibstar Makangila, who's the Executive Director for Circle of Hope in Zambia. Gibstar's going to cover how leveraging HIV community engagement for COVID-19 contact tracing has worked in his country. Gibstar, thank you.
Thank you very much, Melinda. And glad to be here, and greetings from Zambia to all our colleagues on the call. I'm going to talk about what we have done as Circle of Hope under the HIV community engagement that we've been running for several years. Next slide, please. Yeah, we have been founded since the year 2005. And for about 13 years, we had managed to bring or link to treatment approximately 3,500 clients to HIV treatment. And after we redesigned and crafted a community post model approach in 2018 March, we have been able to bring in excess of 23,000 new HIV clients simply by adopting a community-based engagement. And this model has really done wonders, as you shall see from the data that I shall show. And how did we do it? Firstly, like the two previous speakers have said, we have embraced and accepted the fact that communities have persons we call gatekeepers, and these are the ones who are like the influencers in communities. And so we now work with them. And also we've taken those services closer to where people live, work, and socialize. On top of that, we also retrained all our staff in excess of 400 in terms of their level of engagement as far as how they engage in dealing with the communities. And so we identified approximately 5 barriers which have been mentioned by my two previous speakers. One of them, of course, stigma. These community posts are not branded in any way. There are one single room stores in markets, very busy bus stop areas, and churches. And so the lack of branding has sort of reduced stigma to a very large extent. And then we also have a service charter in terms of how much time clients spend at the community post. So on average, a client will spend approximately 30 minutes to 40 minutes. Before the model, people would spend about 5 hours to 6 hours just queuing up to collect antiretroviral drugs. Thirdly, we also have reduced or cut out the cost of going to these health facilities by taking these community posts to where people live, work, and socialize. And number 4, we also have increased the level of customer care. We've introduced a robust customer care approach, and we are currently training over 9,000 Ministry of Health in Zambia staff, healthcare providers in customer care. And last but not least, coordination of all stakeholders working in particular communities has been our strength. Next slide. So this is a picture of how we have utilized a 3-prong approach in carrying out both the HIV work in the communities and also COVID-19, contact tracing, and of course, home-based care. I wanted to mention 3 things in line with what my previous speakers have said. What we have seen and recognized and respected is the fact that for us to succeed in communities, we have to gain trust, as was mentioned earlier. Secondly, we also have to realize that the community influencers or leaders enjoy access to households. So the first thing is trust. Secondly is access to household. And the third and very important thing is how these community gatekeepers, community stakeholders enjoy intricate community knowledge. They understand what's happening in the community, who's who. And so when carrying out contact testing, we have really thrived on these 3 community intricate virtues of trust, access to households, and intricate community knowledge. Next slide. And so in terms of how we have engaged, we have embraced this core value we call the recipe. And it's an acronym standing for how all the staff, all the partners in the community, and by partners, I mean the market executive leaders, membership organizations on the grassroots membership organizations, and all civic leaders, members of parliament have embraced this core value that we developed. And I'll spend 30 seconds to talk about this. In terms of the first core value is the need for us, especially in our continent, to take full responsibility of our issues. And so under responsibility, we've eliminated or killed the mindset or mentality of blaming others. We have blamed everybody else. In the case of COVID, we have also blamed the source of COVID instead of taking responsibility and dealing with the issue of COVID as head on. We have also said enough of excuses. let's find a solution to ensure that our communities are complying. Secondly, we also have talked about the need for us to bring back empathy. We are living in a very hard world now. With COVID coming, most communities are really afflicted. And so as we do contact tracing, as we reach out to these communities, we need to carry empathy and discharge our service empathetically, contact people with empathy. Thirdly, compassion is something that also the communities need. We need to do something about the people's plight in various areas. And of course, like Gabriel had said, integrity is everything for us to sustain that trust, sustain that companionship, and thrive on collaboration. And also, because of the long fight we've had in HIV and other viruses like Ebola, we also need to bring back the issue of passion. We need to engage our communities with passion, let them feel the energy that we love them. We don't just want to use them for statistics, but we are really interested in the whole being of their survival and their sustainability, even beyond COVID. And last but not least, adherence to all ethics set by World Health Organization, the governments in our countries, and also other cooperating agencies such as PEPFAR, CDC, and so on. Next slide. So that's just a picture illustrating a typical community meeting where we had the faith community there, community leaders. We have a counselor there. We have several pastors, and we have our partners from the from CDC HQ and from PEPFAR. This is in one of our flagship carriers in the community post. And this is one single room with over 2,000 clients receiving antiretroviral drugs from one particular room. And currently we have about 138 community posts across the country of Zambia, all begun by Circle of Hope, working with various partners. Next slide. And so we have been utilizing community health workers who work for us under the community post, and these community champions leave the community post daily to go into their communities to not only test for HIV, but conduct COVID screening while taking precaution, and of course, conducting contact tracing in partnership with the Ministry of Health, who are the custodian of all the data in terms of contact tracing, and also dealing with other impact results from COVID, such as violence against women and children, suicide cases, unemployment, and so on. And then once they find persons, then they refer them to the Ministry of Health approved COVID centers. Next slide. So this is typical of our performance as at, this is as at 2019 December. If you notice in around the first quarter of 2018, if you see, when we introduced the community post model with all those elements I mentioned about, this was the change in performance in terms of the number of persons who were agreeing to come and access HIV services. So the increment has been phenomenal. And like the heading of the presentation says, we have seen a 1,200% increase over an 18-month period of people or persons being linked to HIV in the same district, the same city, and the same environment. Next slide. In terms of the strength we have as Circle of Hope is the issue of index testing, which is very closely mirrored to contact tracing. And so our trained community health workers who are trained in customer care and the recipe that I referred to have a very high level of understanding index testing, and in this case of COVID-19 contact tracing. And so if you look at the graph there, we have a 99.9% acceptance of the contacts that have been given by the index. And with that acceptance, we have an elicitation ratio of 1.1 to 2.3. And then out of those who've been elicited and have accepted to be tested, we have 87.8% being tested. Of those, we have an average of 41% coming out positive, and we normally have 100% linkage to treatment. And so we have utilized these skills to engage in contact tracing under COVID-19 outreach to communities. Next slide. So what have we done? We have integrated COVID-19 in the HIV training package for community health workers, faith champions who are the clergy. These are the pastors, the priests, the imams, and other
Oops, it looks like, unfortunately, GoodStar is frozen in the very...
religious
Oh, there you are.
leaders. At the same time, we have embraced the community local leaders who are quite a lot to mention. And all these have embraced the circle of hope and partnering with community influencers. And these community health workers are 19 safety community gatekeepers, elicitation and customer skills acquired from HIV engagement. Next slide. Are we able to get the next slide?
It may be slightly delayed.
Yes, it's a bit frozen, so please continue, Chipstar.
All right. Okay, let me continue.
Apologies. It's going to come soon.
All right. All right. So next we have just a picture which you will see shortly, illustrating some of our community health workers. And after that, we have the last slide, which is showcasing. Let me just wait for the scroll to come. Yes. Okay, that's right. So we have a picture there of showing our community health workers who've been trained in COVID-19 and HIV. And last but not least, I had said earlier that, yes, I said that area, the secret for our success has been collaborating with all IPs and the Ministry of Health. And we have a very strong theme that we need to move away from competition into collaboration. All IPs working in particular catchment areas must collaborate because we all have one goal and one battle against COVID-19 and against HIV. And so this collaboration has led us to respect the skills that are embedded in communities. And most of our programming is now bottom-up approach. We're no longer doing top-down approach. And so we've learned a lot of lessons from the community. And most of these community members have come on board to work with us. We've also been allowed to use these 138 community posts across the country as COVID-19 screening points and contact tracing centers. For sustainability, we have engaged in continuous training as new knowledge keeps emerging in regard to COVID-19. And now we have the vaccines coming in. We are continuously training, getting feedback, and using and utilizing what we call the messages of hope. So much about COVID has been the fear of death, but we've introduced, working with the Ministry of Health and PEPFAR, messages of hope, emphasizing the value of life, of hope, of togetherness, and supporting every single member of the community with a theme that let us not leave anyone behind. And last but not least, we have utilized existing community structures and networks to further our engagement. And these are churches, markets, community halls, and indeed the government structures themselves. So thank you very much for the opportunity to share the Circle of Hope story from Zambia in Lusaka. Thank you.
GoodStar. Thanks for sharing this. It's very interesting. And it's great to see that you were able to build off of something that really worked and was very much trusted in yet another time of need for the community. So thanks so much. So next we're going to move on to yet another case study in Belgium. So we'll be hearing from Jorgen Reymans, who is the medical coordinator for the University of Leuven, who's going to talk about community-based contact tracing in a classic student town. Jorgen, thank you.
Yes, hello everyone. Thanks for having me. I'm a medical doctor and a PhD student, and the last 7 months I've been involved with the university's testing and contact tracing program, which might be of relevance to others implementing programs focusing on young populations or populations living in congregate settings. Next slide. So on the next slide, you will see a slide saying that the city of Leuven is a small town in Belgium with 100,000 local residents and over 50,000 tertiary education students. And these students face particular risks when it comes to COVID. One of them is the fact that they often live in student housing where they have shared facilities. Secondly, they usually don't have a medical care provider in the university town to answer to any questions. And thirdly, and this is a cultural thing, students in Belgium often go home to their parents' house over the weekend, which implies the possibility of spreading COVID over large geographical areas and between generations. Next slide. So on the next slide, you'll see the hospitalization rates per province in Belgium in the last 7 months. And the one highlighted is the region in which Leuven is located. And you'll see that the region has done remarkably well, both with regards to incidence and hospitalization rates. And the east, where Leuven is located, has done even better. We tend to think that very proactive testing and contact tracing by us, but also by the local commune and others, has contributed to this. Next slide. So when we implemented the testing and tracing program, we set forward 3 pillars. And the first one is of most relevance to the presentation of today. And it's that we wanted to put care delivery for students at the center, because we were seeing that they had lots of questions with regards to COVID and didn't really know who to turn to. The second was that we wanted to have very fast testing, free testing, and it had to be very easy for students because they were requesting the possibility to get tested in the university town. And the third thing we focused on was to maximally integrate testing and contact tracing and bring contact tracing to the next level, which to us means very rapid follow-up, same-day testing and tracing, focusing on backward tracing because we knew from last summer that it was very important in COVID, and focusing on student residences because that's where the issues were. Next slide. So for the purpose of learning, I'll go through a couple of bumps in the road we have encountered in the last 7 months and using quotes to explain and then show you how we've tried to find a way around them. The first quote is from a student, a quote we heard many times in the outset of our program, which is, "I don't have my roommate's phone number." So we couldn't follow up on contacts because the phone numbers weren't known to the index case. And we said, fine, we'll go to the homeowners, but they usually said, "I'm not sharing this information. I'll run it by my legal team," which caused massive delays. Next slide. So down below, you see the workaround we devised. So we set together with the data protection officer of the university who followed up on our program very closely, checked the legal basis for requesting this information and set out to develop a standard operating procedure on requesting personally identifiable information to external partners and communicating that widely to the student community and the local homeowners. Next slide. On this graph, you see the percentage of students. So the light blue graph is the percentage of students we should be reaching because they live in a congregate setting with an index case. In the dark blue, you see the number of students or the percentage of them that accept to get tested, and the red is the positives. So over time, this is the last 6 months, you see that we've been reaching a higher percentage of students. We've been persuading them to get tested more easily, and this has been translated in a lower positivity rate. Next slide. The second bump in the road is something we heard very, very often in the outset of our program, which is, "It's my first time doing contact tracing." Next slide. And it relates to the issue of training your contact tracers. So at the outset of our program, we sent out a call first to medical students and then others to say, "Hey, do you want to be part of the pandemic response run by the university? We'll integrate your ideas, you can contribute." And we had a massive response of hundreds of students wanting to collaborate. And we got all excited and planned them in the schedule to do contact tracing, which caused my colleague and me to end up teaching a new person every 4 hours how they should do the phone calls. And that was unworkable. So we decided to hire contact tracing coordinators who are medical doctors who know the local culture. We decided to start working with core team contact tracers who come back regularly, and we've focused heavily on peer-to-peer teaching between contact tracers themselves. Next slide. The third quote and the last quote I'll go through comes from either a student or another. So students would often say, I don't fit the testing criteria. And others, and this can be parents, teachers, homeowners, other responders like medical doctors saying this student doesn't comply with testing criteria. Next slide. So as in many countries, Belgium had strict testing criteria. You need to be a high-risk contact or show a certain number of symptoms to be eligible for a PCR test. And we knew that students often had low symptomatic disease, so they didn't fall into the testing criteria. And then generally the intensity of contacts are underreported. Everyone goes for a walk with friends, but no one throws a party. That's not true, obviously. And then thirdly, the issue we were facing is that others involved in the pandemic response sometimes said, no, this person isn't eligible for the test. And we had reason to think that it was easy for them to say it was a low-risk contact because that involves less follow-up. So the workaround we devised was to interact with the federal government and become a pilot project for a new testing indication where students could decide for themselves whether they were at high risk and therefore needed a diagnostic test. And then we spread the word on that new testing indication widely. Next slide. So we went through social media. Next slide. National media helped a lot in getting the word out. Next slide. And this is something I liked a lot. So we worked together with the police department in the city of Leuven. And now when a student is caught transgressing a particular COVID rule, they don't only get a fine sometimes, but they also get a flyer which refers them for testing in the testing center. We think hereby that we pick up a lot of students who would otherwise be reticent to come to the testing center. And these are the ones often who are at high risk of COVID. Next slide. So this is just a rise in the number of clicks on our testing center website. Next slide. We've seen an increase in the number of tests. This is partly the third wave, but on the next slide, you'll see that our positivity rate has remained relatively stable and far below the national average. Next slide. And this is the testing indications over time. The orange bar down below is the indication risico gelopen, which is I've run a risk. And we see there that the new indication hasn't caused the number of tests being done to blow up. So that's something the federal government was afraid of. Next slide. So just one thing I wanted to add to the presentation on the app. Another marker we could have used to measure community engagement was the uptake of the app in Belgium, and that for us is about 50% amongst the student population. I'm happy to answer any questions going forward.
Thank you so much, Joran. That was really interesting and a nice, different perspective. I have one question on the docket for Gibstar. I know you wrote the answer, but I think others might like to hear the response from you. So the question was, during your engagement with spiritual and religious leaders, did you face some reluctance or mistrust or unwillingness to collaborate when it came to contact tracing? And if so, how did you address that? Gibstar? Gibstar? He's still... Okay, maybe he's left the program. I think I'll, what we like to do at the end of these webinars is to just wrap up with some sort of overarching thoughts about next steps, maybe some gaps we identified throughout the process of hearing others speak today. So as I look for a potential, see if there's any questions for Joran here, I'll start with Tamar and ask if you could just kind of give an overall perspective of what you've heard from today. Tamar, and then I'll go to Gabriella, and then I'll go to a question and final comment from Joran.
Thanks, Mindy. I mean, I think that a lot has been covered today, but I think some of the golden threads of what we've really heard is the importance of trust and everything that comes along with it. So I've already answered sort of that question around approaches to trust building, but I would just leave people with, you know, emphasizing how important that is, and that it's not a concept that's far away and that we can't attain. It's something that we really need to work towards an action. And no matter what resources or the lack of resources we have, there's really no excuse not to build trust with communities. I think we talk a lot about sort of why we can't do community engagement and how difficult it is. But I think we really need to reframe where we're coming from and start building those community-led approaches now into everything that we do, not just contact tracing, but vaccinations, et cetera. And I'll just leave everyone with that. Thanks.
Great. Yeah, we always find that trust is at the core of everything that we do. So thanks for re-emphasizing that. Gabriella, do you have any overarching thoughts having heard the other presenters today?
I would like to talk briefly about another example that's really interesting. I think it's Australia, who managed to really lower figures and infections during the past month and was able to return to a nearly normal way of life. And I think it's an excellent example for, of course, building trust, but also for the merits of contact tracing going hand in hand with a very committed population.
Yeah, that's true. Thank you for recognizing that. Thanks. Gibstar, are you back with us? Any final comments?
Yes, I am, Melinda. Thank you very much.
Sure.
Yes, my final comments are just to reemphasize two quick things. Number one, that most of our approaches and engagement have been from a mass media communication strategy. And what I think communities need is more on a person-to-person conversational strategy. This reinforces trust. And so as we roll out, like Tamar said, any effort to contain a pandemic or a situation, we need to engage both mass media approach and also conversational. And this conversational is important because communities trust their own more than the central government, for instance. The same message delivered centrally will be less effective than if it's delivered by a person on the ground in the community. And so then the second thing I'd like to close with is the efficacy of the faith community. In Zimbabwe and Tanzania and Zambia, where and Nigeria, where we've rolled out this community post, we've seen that the faith community is extremely influential because they already enjoy trust among their parishioners or congregants. And so if we can use this to disseminate most of the messages, this community, that will be well received. And I'm sure the results you've seen from Circle of Hope can easily be replicated, as we have already replicated in Tanzania and Nigeria, and having similar results. Thank you very much.
Great. Thanks, Gibstar. Okay, I'll turn to you, Joran, with the final question and your final comments. So we did have a question that asked if you'd like to comment generally about what you found in terms of risk perception in COVID, since you're working mostly with the younger population, and then any final comments from you as well.
So very variable. Some students are very afraid of COVID, and particularly they're afraid of intergenerational contact. So they're not afraid for themselves, but for their parents, because many of them see their parents very often. The number of students who don't care and act as if they don't care is very low in our population. So we're very happy to have a very positive and motivated population in general. One comment I had is what I find very interesting in our project, but also many other projects I've come across, is that organizations who are usually not very involved in public health responses have stepped in and taken their responsibility during the pandemic. And for example, for our university, I hope that their motivation will be translated into fighting other problems in relation to public health for students. This can be dependency problems, psychosocial problems, sexual health. But I think that it's very nice to see how many organizations have stepped in this pandemic.
Great. Thank you so much. So I think it all comes down to trust, and trust that is existing prior to our next public health emergency. So we need to build that now. Again, and this is a lesson we learn again and again and again, how to really effectively work with communities. And in this case, bring them into the response and have these be largely community-led activities. And then to use those really trusted influencers, the faith organizations, as Gibstar mentioned, and then really seek out some new and unique partnerships of other organizations that might not typically be in a public health emergency, but are willing to step forward and playing their part, as Joran had just mentioned. So thank you, everybody, for your time today. This has been a great array of stories and experiences around this important area for the COVID-19 response. Thanks again, and we'll see you again in 2 weeks. If you have any ideas for the naming of this series, please, again, share them in the chat function or send us an email at EPI-WIN@who.int. Thanks again. Bye-bye.
Thank you. Bye-bye.